Good morning, everyone. Welcome again to my YouTube channel, Pain Free Partha, and my website where you can download and slide more than 350 to 400 slides related to anesthesia and physiology, free of cost, editable. So today I'm going to talk on something on liver physiology, on basic some function test of the liver. If you see from the front, it is right lobe and left lobe. And if you see from the back, it is also caudate lobe and quadrate lobe. You can see the hepatic artery, aorta, IVC, and hepatic veins. The gallbladder with the common bile. That's the portal vein. That is the hepatic arteries. So it has got major anteriorly right lobe and small left lobe, and is technically right, left, caudate, and quadrate. And it all consists of segments and basic lobules. You can see the basic lobules where you can see the portal triad, and this is the sinusoid, the central hepatic vein, hepatocyte, and this is the Cooper cells. This is the basic hepatic lobule. Now, the sinus of the liver is also known as the hepatic asinus, is also the functional unit of the liver. Now, you can see this area around the central vein, organized. This is zone 1, zone 2, zone 3. You can see the zone 1 is close to the vessel. That is why any toxins, the zone 1 is vulnerable. They are crucial in metabolic process, bile production, and nutrient processing. Now, the blood flow is around 1500 ml per minute. It is unique because it gets supplied from the hepatic artery and also from the aorta. You see the hepatic artery goes in and into the liver. Now you see from the aorta there are numerous arteries, splenic artery, superior mesenteric artery, inferior mesenteric artery. All they go to the liver, spleen, small intestine, pancreas. Come to form the portal vein, goes back again to the liver, and from the liver it comes as hepatic vein into the IVC. That is how it has got two blood supplies. One is portal vein, which supplies 70-75%, and this is around 25 to 30%. Why we should need the dual blood supply? The hepatic artery is a source of oxygen-rich blood, and it also supplies, even though it is only 1/3 of the 60 ml, it is mainly the oxygen-rich supply. But in contrast, the portal vein carries nutrient-rich blood from the GI tract, brain, liver to the liver, allowing for processing and detoxification of absorbed substances before they enter the systemic circulation. Okay, so if you take food or something like that toxin, it should not go to the systemic circulation directly. It goes to the superior mesenteric artery, superior mesenteric vein, goes into the portal vein, and then go back to the liver, and then only hepatic vein into the IVC. That is the advantage we have got to detoxify the unnecessary substances. This is about the blood supply. Now we come to the nerve supply. Sympathetic is by the celiac plexus, T7 to T9 spinal nerves. Parasympathetic is by vagus, they form the hepatic plexus. They regulate glucose metabolism and bile secretion. Now, what are the functions of the liver? Why should we have the function liver at all? Now we see we are told it detoxifies blood, it filters blood, it produces bile, it synthesizes proteins, it synthesizes clotting factors, it regulates blood glucose, hepatic glucose output. For example, if you are fasting for so many hours, normal person, glucose is produced from glycogenolysis by the liver, and it regulates, it breaks down fats and cholesterol. It stores vitamins and nutrients. It metabolizes, causes minerals, and it is also involved in the immune system. So these are the various functions of the liver. The carbohydrate metabolism, it regulates blood sugar. Here it synthesizes cholesterol, triglycerides. In protein metabolism, it converts amino acids into proteins. Methionine amino acid is let out for acetylcholine synthesis, and adrenaline synthesis. Drug metabolism. It converts toxic substances into less harmful. Ammonia detoxification. Toxins like alcohols facilitates elimination from the body. These are the metabolic functions. See here, metabolic functions. Now we have synthetic functions, plasma protein synthesis, hormone regulation, bile productions. In the plasma protein, albumin and clotting factors. This is very important. Prothrombin, fibrinogen, heparin. All these proteins are synthesized in the liver. So if you have a less albumin, it is a synthetic function problem. Now, what are the tests available? Now we know the gross idea of blood supply, nerve supply, and what are the functions. What are the tests available to know there's a liver function test? So they are called as liver function tests. And they are classified as so many. We will talk one by one in a short time. Alanine aminotransferase ALT, aspartate aminotransferase AST. They were called as SGOT and SGPT prior. SGOT and SGPT. Alkaline phosphatase, gamma glutamyl transferase, 5-nucleotidase. Basically, now you see they were classified as aminotransferases. What they do, they transfer amino acids. They create a new amino acid or protein, something like that. They synthesize. There are aminotransferases, there are dehydrogenases, and there are phosphatases. These are all the three things, basically. Now you see, this is the liver function test, 5-nucleotidase, direct bilirubin, prothrombin type like a map, LDH, total proteins with albumin, reversal of albumin globulin ratio. All these things are tests of liver function. Now, this is a normal thing. Bilirubin is 0.3 to 1. The normal, you can see here, GGT is around 40, alkaline is around 100, aminotransferase is around 30 to 40 range, AST is around EC, AST is SGOT, ALT is SGPT. Alkaline phosphatase, gamma serum albumin is normally around 4, globulin is around 3, albumin globulin ratio is there, prothrombin time is normally around 12. The 5-nucleotidase is around 2 to 17 units. LDH is around 140. These are the normal values of LF. The aminotransferases included AST and ALT. Now, as the aminotransferases are markers of hepatocellular injury where ALT is more specific. We know, beware, but half-life of ALT is 48 hours. Don't test it again. ALT may be definitely not decrease around 48 hours less. So we have to know, even if we test, find out an increase or decrease, we have to know the half-life of ALT may be around 48 hours. It is directly hepatocellular injury. It is not synthetic function. But in newborn, in pregnancy, males, obesity, the levels may alter. So unless you have a clinical scenario, you cannot interpret test. This is a basic thing for any test. Alkaline phosphatase, now you know AST, ALT, all are things for hepatocellular injuries. Alkaline phosphatase is a part of zinc metalloenzymes. They are highly concentrated in the bile canalicus, also in bones intestines. So that is why biliary canaliculus obstruction, the alkaline phosphatase is increased. GGT is increased. These two are more specific for obstruction. It is not basically hepatocellular injuries. Alkaline phosphatase, GGTs, and 5-nucleotidases. These are more for obstructive liver disease. Elevated ferric may be liver disease, particularly cholestasis. Sometimes we can exclude because that alkaline phosphatase may also be increased in bone disease. But 5-nucleotidase slightly can prefer liver problems. Bilirubin is the end product of heme catabolism. From the RBC, from the hemoglobin, heme that is converted into bilirubin. That's what they call it as rubin. Rubin means red, with 80% derived from hemoglobin. Unconjugated bilirubin is transported to the liver, loosely bound to albumin. Now, the unconjugated bilirubin is water insoluble. It cannot be excreted in the urine. So, what does it do? Bilirubin is conjugated to conjugated bilirubin. It becomes water soluble. It appears in the urine. Now, bilirubin glucuronide, it is secreted into the bile and lung. If there is a problem, then it will not, if there is a CBD obstruction, it will not enter the gut. The bilirubin conjugated will not enter the gut. So the stools are pale. But more conjugated bilirubin will go into the blood and urine. That is why urine are darkish yellow in obstructive disease. That is CBD obstruction. This is a bile formation from the gallbladder, common bile duct into the duodenum. That is why if we have a common bile duct obstruction, it will not go to the duodenum and intestine. It will go to the blood. This is pre-hepatic jaundice. I have already told bilirubin is an end product. Heme metabolism. Now hemolysis, and this is more of hemolysis. For example, a spirocytosis. Then it becomes a pre-hepatic jaundice. When there is a liver injury, then it is a hepatic jaundice. When there is a CBD obstruction, then it is an obstructive jaundice. These are the basic three types of jaundice. Now, in pre-hepatic jaundice, will you get any synthetic function problem? Less. In post-hepatic jaundice, it may not be, but here it may be. Here, alkaline phosphatase and 5-nucleotide may be increased. Here, AST, ALT, and bilirubin mainly. Here, there is unconjugated bilirubin. Now I can see prehepatic, unconjugated bilirubin, normal conjugated bilirubin. Because there is a blood cell problem, elevated reticulocyte count, and dark urine immunoglobulin may be increased. Here in hepatic, there may be both conjugated and unconjugated. Liver enzymes are high. That is very important. Maybe some obstruction, but liver enzymes are very high. In post-hepatic or obstructive, conjugated bilirubin is high, especially alkaline phosphatase is high, 5-nucleotide is high, gamma glutamate transferase is high. These are the differences. Now we will go to the synthetic function test. Now we know albumin is synthesized. So albumin decrease is associated with synthetic function problem. But if we have an enteropathy, it may not be true. The proteins will be lost. What you need is only 10% of the normal hepatocyte mass to have a plasma normal albumin. So if you have an hepatocyte mass only 10 to 15%, you will maintain normal albumin. That is in routine cases. We're not talking about rare diseases. The prothrombin time is also a synthetic function. Now, synthetic function, what are the two things? Number one, albumin. Number two, prothrombin. These are the two important things. Leave alone hormone synthesis and all. It takes a blood to clot after a tissue factor. Now, the normal clotting time is 7 to 8 minutes or from 5 to 8 minutes. Now, you add thromboplastin in this and make it clot faster. So, now you need certain extrinsic clotting factors like 2, 5, 7, 10 to make it clot fast. If that is not there, the system is not working, then the prothrombin time will not be there around 13 seconds. It will be 26 seconds, 40 seconds. I will have a separate video of prothrombin time already had. You can have from painfreepartha.com or YouTube pain-free partha. A prolonged PT may be a deficiency, liver disease, or a vitamin K deficiency because they are vitamin K dependent factors. There is an obstruction, vitamin K is not absorbed, and these vitamin K dependent factors may not be produced. So if you inject vitamin K, then your clotting factors may be bigger. But if there is a hepatocellular injury at all, even if you inject vitamin K, unless there is an active phase, the clotting factors may not increase. Serology is not HbSAg, HbA. This is about autoantibodies classifying liver diseases like this. They are not very particularly concerned with anesthesia. ALT is altered, but no liver disease. There may be diurnal variations in both healthy individuals and cirrhosis. So liver diseases, 45% variation has been seen. Metronidazole may alter with ALT. Hypothyroidism and hyperthyroidism may be altered with ALT. Methotrexate, Folitrax, what we use commonly once or twice a week, may cause elevations in LFT. Liver fibrosis, chronic alcohol intake or methyl dopa. Ergot alkaloids may cause this. Oral contraceptives may cause obstruction. So OC pills, the commonest. If you come to see some mild elevation, go for the history of drugs, especially OC pills. In anesthesia perspectives, chronic alcoholics tolerate barbiturate better because they have enzyme induction. After general anesthesia, liver blood flow may be decreased up to 20-30%. The reduction is primarily due to anesthetic agents on SVR and cardiac output. There may be a decrease in splanchnic blood flow, but we will maintain cardiac output. The exact degree of reduction can be varied based on the type of anesthetic used, patient physiology, and other intraoperative factors. What is the patient like? Already the patient is compensated. Already the patient is having a septic shock. BP is problematic. There we reduce. Further blood flow will be reduced to the liver. What is halothane hepatitis? Halothane hepatitis refers to a serious, but this is halothane is almost not prepared. All few companies prepared to stop it in India. Serious form of liver injury, immune mediated. The risk factors are repeated exposure, obesity, female, pre-existing liver disease. So if you have repeated exposure, obesity, female, pre-existing liver disease, avoid halothane. It is usually present as increased liver enzymes, abdominal pain. Now you see, it is not that immediately. 1 to 3 weeks after exposure to halothane, severe cases can progress to acute liver failure. We cannot do anything. Diagnosis is clinical, supported by LFT. We should do other causes of this thing. Liver biopsy may show necrosis and infiltrates. What we need to remember is 1 to 3 weeks after exposure to halothane. What is management entails? Nothing. Supportive care, wait for the liver to get better. So alternate anesthetic agents. If you have a obese female susceptible to the halothane and especially repeated exposure, avoid the halothane. There is one more thing. You see here hypocapnia and liver. You see this liver. This is around less than 30. Here if you see the PCO2, it comes to here and there. So liver blood flow is maintained in this PCO2. See here hypocapnia. Where does it go? If the liver, it goes to skin and muscles where the surgeon is operating. It is difficult for him. So if you keep hypocapnia, the liver blood flow is decreased. This blood will go to the skin and muscles and problematic for the operating surgeon. Spinal anesthesia reduces liver blood flow, largely MAP decrease. Because we are told the sympathetic from T7 to T9 from the celiac plexus. The effect is a primarily decreased in portal venous flow, systemic hypotension, splanchnic vascular resistance slight decrease, but total blood flow is consistently decreased, and the main target is portal venous blood flow. So what we are thinking, why do you want to stress this in anesthesia? We have told about anesthetic agents, cardiac output, hypocapnia, spinal and hypotension. Now we have hypothermia. Decreased blood flow, coagulation problem, decreased metabolism, inflammatory. All these things may also problematic to anesthetics. Noradrenaline primarily decreases liver blood flow by constricting the hepatic artery and portal vein. But the effect on portal vein may be more variable. But adrenaline shifts, but not much change. Now we know liver has got 4 lobes, right, left, quadrate. The physiology is about so many functions of the liver we know. Immune function, detoxification, synthetic function, fat metabolism, carbohydrate metabolism, protein metabolism, metabolism of fats, so many things. Blood flow is around 1500 ml per minute, where the portal venous is around 75%. We need nutrients to be detoxified, where the hepatic artery supplies oxygen-rich blood. So T7 to T9, sympathetic, parasympathetic is from the vagus. Test we know AST, ALT, hepatocellular injury, preferably ALT, alkaline phosphatase, GGT, and 5-nucleophilase. Obstructive functions. Conjugated bilirubinemia, obstruction. Unconjugated hyperbilirubinemia, hemolysis. Anesthesia concerns are maintain the cardiac output, maintain normocapnia, maintain normothermia. Thank you very much. Visit me at Pain Free Partha.